My name is Sini Waka, and I will be talking about the osteosarcoma cancer. So what is osteosarcoma? It is the most prevalent major aggressive bone cancer found in mostly children and teenagers. Although it can occur in any bone, it usually begins in the long bones of the arms or legs. It is rare, but can happen in the soft tissues outside the bone as well. Osteosarcoma originates from osteoblasts, which are primary bone-forming cells. Osteoids, or malformed immature bones, is produced by cancer cells. So there are two different types of osteosarcomas. There's primary osteosarcomas and secondary osteosarcomas. Primary means that the osteosarcoma develops as a result of an aberration in bone growth, while secondary happens as a result from another arising health concern. Secondary osteosarcomas tend to be referred to as a higher grade tumor. Primary osteosarcoma comes in three main types. The first being intramedullary or central. This is the most common. The medullary cavity of a long bone, for example, the femur, is where these bone tumors form. Furthermore, intramedullary osteosarcoma has several classifications, each being based from the kind of cells that produce the tumor. So there is osteoblastic, it is the hard bone material, is created from cells. Chondroblastic, cells resemble cartilage. Fibroblastic, fibrous connective tissue is made of cells. Small cell, tiny cancer cells, and it's very rare. And then there is epithelioid. Uncommon, it is rapidly expanding type with blood-filled cavities. The second type of primary osteosarcoma is juxtacortical or surface. 10 to 15% of the total diagnoses are of this type, which is the second most prevalent. The periosteum, the thick layer of connective tissue that surrounds the bones, or the outside of the bones, are where these bone malignancies occur. Juxtacortical osteosarcoma also has a few classifications, them being periostal, grows gradually on the surface of the bone, or periostal, grows on the bone's outer layer rather quickly. High-grade surface. It is growth on the surface of the bone that is uncommon and grows quickly. Lastly, there is extraskeletal osteosarcoma. Less than 5% of diagnoses are of this sort, making it very rare. These tumors develop in soft tissues and are not connected to bone. They most commonly appear where radiation therapy has previously been administered. The epidemiology. In the U.S., around 1,000 new instances of osteosarcoma are reported annually. Children and teenagers account for approximately 50% of this. Osteosarcomas account for 2 to 3% of children malignancies, but a far lower proportion of adult tumors. Children, teenagers, and young adults within the years of 10 to 30 are most commonly affected by osteosarcomas. This cancer can strike anyone at any age, however, teenagers are the most commonly affected age group. People over 60 have about a 1 in 5 chance to get this cancer. The location of the tumor and whether the disease has metastasized at the time of diagnosis are two of the numerous variables that affect an individual's outcome for osteosarcoma. So the rate of incidence is 3 to 4 cases per million people each year. Survival rate, if it is localized, which means it's found before spreading, it's 60 to 70%. Metastatic osteosarcoma, which means it's already been spread when it was found, is 5 to 30%. For genders, males have a slightly higher rate than females, about 1.2 to 1.6 ratio. Ethnicity, Black and Hispanic individuals have a greater incidence than non-Hispanic white groups. The incidence of osteosarcoma is around 11% to 15% greater in Black and Hispanic children and adolescents than in their non-Hispanic white counterparts. According to reports, the annual incidence rates are roughly 6.8 per million for Black people, 6.5 per million for Hispanic people, and 4.6 per million for white people. Leukocyte telomere length, which tends to be longer in African American and Hispanic populations, is one aspect that researchers examine as a possible biological contributor to particular cancer risks. The peak age for osteosarcoma is 10 to 30. For risk factors, there are no known risk factors for osteosarcoma in the majority of cases, but the following variables may make osteosarcoma more likely. This includes certain disorders that are inherited, such as Bloom syndrome, Li-Fraumeni syndrome, Werner syndrome, Rothman-Thompson syndrome, and inherited retinoblastoma. Other disorders of the bones, this includes fibrous dysplasia and Paget's disease of the bone. And lastly, previous chemotherapy or radiation therapy. I just want to make it clear that osteosarcoma cannot be prevented. The most typical symptom is chronic bone pain that progressively gets worse with time. There may also be swelling and an obvious lump. Since the tumor compromises the bone, some individuals have fractures or limited joint mobility. Patients typically seek medical attention as a result of these symptoms. For diagnosis and staging, a physical examination may be the first step in diagnosing osteosarcoma. There may be additional exams and processes based on the exam results. Imaging tests provide images of the body. They can display the size and location of an osteosarcoma. MRI and X-rays are possible tests. There is also a CT, bone examination, and a PET scan. The MSTS system, also known as the Anneking system, divides tumors into stages 1 through 3 based on their grade, a low GI or a high G2. Whether they remain within the bone, intracompartmental T1, or move outside of it, extracompartmental T2. And if they have metastasized M0 or M1, there is also AGCC-TNM system. The system groups malignancies into Roman numerals 1 through 5 based on tumor size and number of locations, T, adjacent lymph nodes dissemination, N, distant organ spread, M, and cell grade, G. Genes and pathways responsible for osteosarcoma. TP53 and RB1 are two significant tumor suppressor genes implicated in osteosarcoma. TP53 typically fixes damaged DNA or, in the event that repair is not possible, initiates apoptosis. RB1 regulates the cell's cycle progression. These defense systems are eliminated by mutations in either gene, allowing injured cells to proliferate. The cell cycle pathway, the RB and P53 pathways cooperate to control healthy cell proliferation. In order to facilitate DNA repair, P53 stops the cell cycle. Until cells are ready, RB keeps them from starting DNA replication. These processes are upset in osteosarcoma, which leads to unchecked cell division and the accumulation of new mutations. Additional mutations and metastasize. Additional genetic alterations can further inhibit P53 activity or accelerate cell cycle progression, include MDM2 overexpression and CDK4 stimulation in some cancers. The lungs are the most frequent location of metastasis for osteosarcoma cells, which infect adjacent tissue and travel through the circulation. For treatment, chemotherapy and surgery are the most common treatments for osteosarcoma. In rare cases, radiation therapy may also be a possibility if surgery is not an option for treating the malignancy. Eliminating every cancer cell is the aim of surgery. Medical staff considers how the procedure may impact you or your kids' day-to-day activities, the size and location of the malignancy, among other things, to determine how much surgery is necessary for osteosarcoma. So for chemotherapy, it uses powerful medications to treat cancer. Chemotherapy is frequently administered prior to surgery for osteosarcoma. It can reduce the size of the malignancy and facilitate its removal. Chemotherapy treatments may be utilized to eradicate any cancer cells that may still be present after surgery. Chemotherapy may help reduce pain and decrease the growth of osteosarcoma that reappears following surgery or develops to other parts of the body. Radiation therapy. It uses strong energy beams to treat cancer. Protons, X-rays, and other sources may provide the energy. A machine rotates your body while you lay on a table for radiation therapy. The device targets certain areas of your body with radiation. Osteosarcoma is rarely treated with radiation. If surgery is unable to completely eradicate the cancer, radiation therapy may be recommended. So the following procedures are used to treat osteosarcomas. The limb-sparing surgery, it involves merely removing the malignancy. The majority of osteosarcoma surgeries can be performed in a technique that completely eliminates the cancer while leaving the arm or leg intact. The extent of the malignancy and the amount of muscle and tissue that must be removed determine whether this kind of surgery is an option. The surgeon will reconstruct the bone if a portion of it is removed. The circumstances determine whether the bone is repaired. Bone grafts and metal implants are also options. Removal of the afflicted arm or leg through surgery, also known as amputation. In rare cases, a surgeon may remove the afflicted arm or limb in order to eradicate all of the cancer. A prosthetic arm or leg may be utilized following surgery. And lastly, surgery for the removal of the leg's bottom part, also known as rotationplasty. For osteosarcoma within and around the knee joint, rotationplasty may be a possibility. The cancer and its surrounding tissue, including the knee joint, are removed by the surgeon during this procedure. On the portion of the leg that is still above the knee, the foot and ankle undergo rotation and placed backward. After then, the ankle functions as a knee. For the foot and lower leg, a prosthesis is employed. For younger children who are still grown, their surgery can occasionally be a smart choice, and it enables them to engage in physical activities and sports. And lastly, here are my references.